Thanks everybody for being here this afternoon. We're going to talk about transferring my patient to the trauma center. Before we get started, I'd like to see a show of hands of how many people are pre-hospital. How many EMTs, how many paramedics do we have in here? Raise them high. Excellent. Okay. How many people work in community emergency departments? Okay. And how many people work in a trauma center? Okay. So we're going to utilize this time this afternoon to review some patient cases and discuss the importance of communication between all disciplines. Mrs. McKenna spoke earlier about how important it was that communication is key to everything, and that is so true, which you'll learn from some of the patient cases that we're going to review. Now, this breakout session is going to be a little bit different. It's going to be audience participation, it's going to be interactive, and you all are going to participate in some educational skits. It is 3:30 in the afternoon. I know you had a good lunch, so we're going to send you away with your blood pressure up and not being sleepy this afternoon. So, I need some volunteers. I need 2 people to be my pre-hospital folks. And if I were you, I would volunteer now because we have more and we will just be selecting people. This is going to be fun, I promise. 2 pre-hospital people. Yay, we have a lady here.
Meg, way to go, Meg.
Okay. I need you to come right on up here or right here with one of these chairs. And one more person for pre-hospital, please. Come on, or I'm going to pick somebody.
You're a medic, aren't you? Medic? Be a medic.
Yay, Notre Dame t-shirt. Come on, you can be our volunteer. Okay, so we have some objectives that we want to talk about, and some of the objectives we want to talk about how important it is for communication between all levels of healthcare providers, those people who work out in the field, because for those of us, some of us who have never worked pre-hospital, it is a very different environment. And those pre-hospital people can attest to that. We also want to discuss some anticipated needs and differential diagnosis, transport considerations. We also want to improve family communication. I know we've had some speakers today to speak to the fact of how important it is to include family. We also want to identify ways to improve some handoff communication. For those of you who are familiar with SBAR communication, I know the organization, at our hospital, we will be participating in some ongoing safety education classes where SBAR is a major component of some of this training. So, with further ado, I need to have 2 more people for volunteer to be the closest emergency department staff. I need 2 people, please. If not, I'm going to pick 2. How about you 2 ladies right there? And if you would, just meet me at the elevator at the back. And now I need 4 people to be pediatric trauma center staff.
Not you.
4 people.
You do it every day.
4 people. This lady here will be 1. And 2. And 1 more person. 1 more person. How about one of you ladies here in the green, in the front? And if you would meet me out at the elevator as well. And then Jonathan is going to go over some other things, and we're going to come back in here as a group and talk about some scenarios and debrief. Thank you.
Hey everybody, it's almost over, right? So, any of y'all been part of transferring a pediatric patient out? Either that, transferring them out of your ED, or been one on the other end to where you're admitting a patient that's coming into the level 1 trauma center. Anybody been a part of that ever? It's pretty stressful, isn't it? Trying to get your patient taken care of, the family updated, all the charting that you need. It can be really stressful. And I kind of put this picture, you really can't see it, but like, do you really want that girl right there at the head? She looks like she's about ready to pass out. Anyway, so it's a lot, and it takes kind of all times. And like, so the flow of this, and I guess to try to get you an understanding of what we're doing, we're giving you some pre-hospital scenario of this patient. So when this patient gets picked up either in the field or at their home, right? The referral center, the EMS is tasked with, in a trauma situation, to take that patient to the closest facility. And that may not be your level 1 trauma center, it may be that community hospital. And they're tasked with stabilizing that patient and then transferring that patient to a level 1 trauma center. So we're going to kind of appreciate all three of those touches that the patient gets in each one, and kind of talk about communication between those three areas. So it's going to be fun, and we're going to run through some cases, and the cases here aren't like made up and really not believable cases. They're actually several cases that we've had that are real. Some of you that work with us may recognize some of the patient scenarios, some of you may not. So anyway, this is real. This could happen, right, Meg? You could be down there hanging out at High Point Regional and see them. So what I'm going to do is kind of set the stage, and you guys in the audience out here are going to kind of be, I want you all to be thinking, if you were the pre-hospital, if you were that receiving ED, kind of get in your mindset about some of the things that you would be interested as that nurse or as that team member that's going to take care of that pediatric patient, okay? So this is my pre-hospital people. Meg, and your name? Tracy. Meg and Tracy are pre-hospital people. You got to give it up to pre-hospital because they work out of their bags. They don't have an ICU or 55,000 people in their truck. They usually have a primary and a secondary. So they get dispatched out on their page or on their radio, their 800 radio, and it says, you're going to a residence for a 2-year-old that has had dusky spells and altered mental status. So you guys are in your bus. You're going to pick up this 2-year-old at home, dusky spells, altered mental status. And you guys arrive on the scene at the resident's house. Tell me about some of the things that you're going to want to do as a pre-hospital, or if you don't work pre-hospital, what you would expect pre-hospital to kind of address when you go there. What's some of the first things that you'd want to be interested in? History. So you guys get on scene, and Mama is there, and she tells you that this 2-year-old turned blue and got floppy. And she called 911, and she's in a panic. First time. Playing, being healthy, you know, and just fell out. Tracy, what do you want to do for him? Uh-huh. Okay, so your level of consciousness, he's kind of, we'll say he's a GCS of 10. Airway is patent. Breathing is fine. Looks good to you. He's kind of got this like stare, like 1,000-yard stare out, but other than that, looks okay. Blood sugar, okay. His blood sugar is 114. Okay. Physical exam, you get him trauma naked, right? No, not really. That your eyes can appreciate. Yeah. Mom and Dad are fighting. They're blaming each other. Okay.
I probably would have done that in that, kids this age don't usually
All right.
rock over.
How are you going to package your patient? Or are you ready to package your patient?
Do it, you said John Lincoln's on his mark, correct?
Yes, sir.
And you said he's still in his mark.
GCS of 10.
Honestly, no signs of it. If I don't suspect trauma,
Huh?
I probably wouldn't forward it on file.
Okay.
However, it's been a common fact.
You're right. I mean, if there's nothing there that's obvious, you're going to put him on your stretcher and ready to go home. You ready to go home? Like,
Ready to go to bus.
okay, let's go to the bus. You guys successfully load your patient on the stretcher. He is in your ambulance, and you are getting ready to go. The nearest ED to you is 5 miles. The trauma center is about 45 minutes away. So you're going to go to the nearest ED. Okay?
Is he on a monitor?
He EMS in the back of the truck puts him on the Zoll monitor.
Have you already done full vital signs?
We haven't yet. We're getting ready to get there, though. Hey, girls. Go shorties. It's your birthday. So you all are our closest hospital. This is EMS folks, and they've just been out to pick up a patient. So they're going to encode to you. They're going to like, y'all work in the ED? No? Transport? So you guys sort of know what that means. So they're going to radio, like encode, tell you what they've got, what their impression is, and then once they get there, they're going to actually hand off the patient to you as well, okay? So my pre-hospital people, if you want to go ahead based on what we've talked about, give the closest hospital your encoding and report.
How old is this patient? So we've got a 2-year-old male, college, success, responses, GCS of 10, no sign of trauma, code, vital signs. I'm assuming it's vital signs.
Vital signs are stable.
Vital signs are going good. We have ETA about 5 minutes, set on the cardiac monitor. Whatever we find on the cardiac monitor, definitely IV line. If possible. I'm sorry.
This working? Can you? Okay. Probably got him on oxygen, IV lines. We have an ETA of about 5, I think you said 5 miles, so it'd probably be 3 to 5 minutes.
Okay, you pull up to the ED, you're there with your patient. You did put him on a non-rebreather mask. You were not able to get an IV in, and now you need to hand off. Now that you've encoded, you've got to take your patient, move him over to the hospital bed in the ER. Anything else different or anything you want to tell them? How would you go about this if this was real and you're going into an ED and you're talking to these people that are getting ready to take over care for this patient?
Well, being that you said I did not get an IV.
Did not.
I just transfer that information over. We were unable to advise, or unable to obtain IV access.
Okay. Good job. All right, so pre-hospital, you're done. Okay, so you guys are my closest ED, and you've got your patient now. So what you want to know, what you want to do, you're the charge nurse there. You are helping orchestrate this admission. So, and your physician's seeing 3 other patients down the hall. One's a STEMI. So what do you want to do?
Sorry, can you hear me now?
You wanted to know,
Mechanism of injury, what was going on at the time that the child was found?
okay, so in pre-hospital, they told you that the child was 2 and having dusky. Did they explain anything different than that? Okay. So right now, mechanism, we're really unclear on. Okay, what else?
To do a physical assessment on the child.
Great. What you want to do first?
Definitely ABCs first.
Okay, he has an airway. He is breathing on his own, and his circulation looks fine. He's normal sinus on the monitor.
Okay. would definitely go ahead, I'll also get an IV in. Whether
Great.
it's a peripheral or an IO.
Okay. I mean, he's pretty awake. I wouldn't drill on him yet, but so we're going to get a PIV. Anything you want to get with your PIV, or are you good?
Basic labs.
Okay. What does that include usually?
CMP, CBC,
CMP, CBC?
and we don't know any kind of medical history on him, whether he's
No
a
past
healthy
medical,
child.
no past surgical. Okay. Blood gas? Yeah, okay. All right. Anything else?
We do some x-rays,
Okay. What do you want to get?
definitely a chest,
Okay, chest x-ray,
maybe abdomen,
KUV. Okay.
maybe
What?
CT of the head.
Hey.
We don't know what the injury is. I mean, it could be anything from a fall to, it's hard to tell. Could have some congenital type issues.
Well, again, you've got a patient that's got an altered level of consciousness at 2 years old. There's an unclear mechanism. Your ED may have protocols in place that says if you got somebody that has an altered LOC or has a mechanism of injury that suspect a head injury, you would go ahead and run them through a CT scanner. Okay. Based on your CT of the head that you get, your ED physician comes back to you and he says, this child has a large subdural hematoma. He needs to be transferred to the level 1 trauma center for additional subspecialty workup. He's worried because with that big bleed that he's going to supersede the care at your facility right now. So your next job then would be to facilitate transport, right? To get this patient out of your ED and get him, to a pediatric level 1 trauma center. What are you going to need to do? You've kind of got all of this stuff that you've got started. You're going to have to call, right? You're going to have to call and arrange that transport. What else? Yeah. We won't say no, I promise.
Copies of everything that we've already done.
Yeah, and that's stressful, isn't it,
CTs
right?
and labs.
Because why would you get all of this stuff and then when you're transferring, not share that with the rest of the people, right? So I'm bringing in our last set of folks, which is your level 1 trauma center folks, and we'll see what they do. Tamara, come on down. Are you delegating already? Okay. So look, some of these faces look very familiar. Okay, so this is your level 1 trauma center, your pediatric level 1 trauma center that you're transferring your patient to. So if you could, just give them a report on kind of what you know, what you've done, and then we'll talk to them last.
EMS brought us in a 2-year-old, unresponsive, unknown mechanism of injury. They were unable to get an IV. We have gotten one established. He's got a non-rebreather on. He has had lab work done and a CT which showed a left subdural hematoma. And that's more than we can handle here, so we would like to transfer to your facility.
So my girls here, you just took your encode, right? Your charge down there. You know that this is coming to you, right? This has been in an outlying facility, and this patient is coming to you. So tell me what you would do, because these are your helpers, right? You're going to be in one of the 2 warm rooms over there. Tell me what you're going to do in order to get ready for this admission.
A take report and then go talk to the attending.
Okay. And Dr. Babb said, yep, he's be here in 5 minutes.
And then we're going to alert the trauma team
Okay.
that we've got a level 2 coming in.
So you alerted your trauma team, and we're going to level at a level 2. Okay? So we're all standing in there. We've got our gowns and masks on. Who's doing what?
We've got a resident at the head of the bed, setting everything up for our airway. And we are trying, the charge nurse is usually going to try to give a report as best she can on what she knows
Right.
that we've got coming in.
So these are your 3 people that said, hey, we're here to help you.
Okay, I need someone getting
Bye-bye.
everything ready, our airway stuff. We want to start preparing to get some more IV
Okay.
equipment ready so we can get another access.
Huh?
We usually have respiratory therapy come down. We get them there. We've got respiratory here and a couple of more nurses getting the room all set up.
Okay. So Jane's your therapist there. She's said that she's going to help the resident make sure that they choose the right size ET tube with the right blade. We've got a person that's going to do a manual blood pressure cuff and get a secondary line for you. And we also have somebody that can run meds, and somebody else will be charting her.
Right, like
So-
get somebody to chart.
So knowing what you know about this patient coming in, you do know that he has a subdural. Is there anything else that you would be interested in, or like a heads up that maybe your attending has shared with you, or that you've got in the back of your head that you're thinking about?
Neuro, surgery consult.
Sure.
They'll probably want another CT scan done. We'll have to get lab work.
Uh-huh.
Try to figure out what the mechanism of injury was. Is
Right.
what they're going to want to know more than anything
And sometimes
prior
that's-
to
right.
coming in.
In transport, so this patient's coming to you, transport team calls and says, hey, you know what, this kid just had about a 5-minute full-blown tonic seizure. We've given him 2 doses of Ativan that has taken him down now. His GCS is around 8 and 9, and they're about 2 minutes out. So they've saw seizures. They've tried to do what they can do in the back of the bus until they get there.
We're going to probably set up to intubate when he
Right.
gets to the ED.
Right.
So we'll get everything ready for that.
And for the purposes of people that may not know how a trauma admission works in our facility, can you just briefly describe how the primary and secondary are done?
When the patient comes in, there's usually a resident at the head of the bed, and the first thing they're assessing is the airway. We got to make sure it's patent and they can maintain their own airway, or if they're intubated when we get them, they're checking the intubation, the tube, make sure all of that's okay. Then they go from head to toe, and they're looking at any obvious injuries or any injuries that they could have based on the mechanism of injury. If the child's alert, if they can talk to us, they're looking at pupils, ears, nose, mouth, chest. They're listening for breath sounds, checking their abdomen and arms and legs. That's usually your primary assessment. Then they go on to the secondary assessment, which is a little bit not quite as intense. The airway with the primary assessment is the most important.
Right.
With the secondary, they are looking at any other injuries that are obvious that they can see.
Great.
And then we go from there. And then you start ordering all their trauma labs and x-rays and scans, whatever.
Okay. Thank you all. Thank you all. Have a seat. Just leave these up here because people will be up here in a minute. So out there, those of you that did not get a chance to participate in this, how do you feel like that communication went between pre-hospital, closest ED, and your level 1 trauma center? How do you feel like that communication went?
No one mentioned the family. Yeah.
Okay, so we left out the family. All right, what else? Come on, y'all are nurses, you know this. Huh? Yeah, we really were unclear on that, weren't we? It's like not really quite for sure what made. Yeah, right. And in the ED, have you ever noticed when pre-hospital or transport services bringing in a patient, it's kind of chaotic in there. And if we're not giving those folks the attention, the due attention that they need to kind of give us that information, it could either be missed or we just didn't hear it, right? Some EDs have like that whole moment of silence to where when you're getting at trauma admission, it is quiet, like you can hear a pin drop, except for the people that are giving report off. The minute that they've handed off that patient, that's when that primary and secondary surveys start to happen. But it can be very confusing when, you know, in the ED there's 45 people standing and the door's wide open and the temperature's cold in there because everybody wants to be in there but nobody wants to do much. But anyway, that's kind of the key. What other things were you thinking about with this 2-year-old that got the dusky altered LOC?
I didn't hear the blood sugar reported, the 114 blood sugar, and that would be the first thing I'd think about as far as lung function.
Yeah, I mean, you got somebody unresponsive. Is it because of hypoglycemia? The medic out in the field checked. It was okay, but it might not have gotten passed along, right? Most EDs are going to repeat labs anyway, but it'd be nice to hear what we were in the field. Yes, ma'am.
I was gonna little bit more history and ask some questions about meds in the home, drugs.
Yeah.
He's 2 years old, so he's gonna be getting everything.
Yeah, right? Like mom and dad liked the Lortab, and I don't know why Johnny fell out. Maybe it's because they got into the Lortab, right? Who knows? Or maybe they have hypertension and they got hold of the beta blocker. I don't know, right? So, and that probably is going to come more from the scene. Pre-hospital folks are pretty intuitive to get trained about scene safety and scene size up. So when you walk in there, you're trying to like do a whole bunch of assessments all at once. Again, if it's not told to me, I can't assume it though, right? What else?
The blood gas. What did the blood gas look like?
Blood gas was okay. Yeah. What about in the referral ED, they had a large subdural hematoma. Any other labs? Because they would got labs. They said, I think, CBC, CMP. What lab results would you be interested in on that? Okay. Yeah, let's say that your hemoglobin was 7 and your hematocrit was 23. Having that information, it may help you to help that patient if you wanted to start transfusing that patient. You will have to get a second line and you'll have to type and cross and all of that, right? And that takes time, right?
You're also going to do a blood culture to rule out an infection.
Yeah, I mean,
Meningitis or something.
could be he's got the funk in the CSF and you got to help him out there too, right? Did you feel like it was streamlined and smooth? Did you feel like what started off at the beginning in the field was the thing that got at the end at your level 1? Or did it change? Or is it fragmented?
I think it went fairly well considering the roles of people and what their previous knowledge is.
Right.
I thought it did well.
I don't even know what a GCS is. What is it?
So in a trauma, and particularly somebody that has an altered state, they'll do a Glasgow coma scale. You like them to be like 15. The lowest they can be is 3. The lower the number, the worse, as far as your...
As far as I'm telling you.
Good question.
NICU doesn't use that.
No. Yes, ma'am.
One of the things that confuses and makes the process complicated is that you're not always talking to the person who's taking care of that patient. If you call your report, or if you're calling to report to somebody, if you're in a level 3 facility or a level 1 trauma in the bay, and there's 4 people working, I might be calling for a
Right.
and so when you get there, you may not, you're walking into something that you're not really the expectation. And I've also noticed in the that, well, I already see people here too, but they want to know if you're coming in to 20-bed ED or 25, how many beds we have. Are they breathing? Are they conscious? Are they, are they intubated?
Right.
That's all they want to know when you get there. So there's a lot of different things that go into being a little bit less communicative than you think. The physicians are talking on a whole different level, on a whole different line, and sometimes having that set in your head, what you need to tell someone, or what I've interrupted a physician who interrupted me and said, I don't even know what color hat they're wearing. And he asked another question. Well, I didn't just want any more questions. You know,
And Nicole was right. I mean, sometimes they just want the minimal information, right? Like, is he alive? And how long are you going to be? I think there's, again, most of us, as far as nursing goes, when you think back to when you were bedside nursing and you were going off and somebody else was coming on, you always gave your change of shift report, right? If you just said to the nurse coming on, my patient's alive, see you tonight in 12 hours, that's really a professional discourtesy, right? You didn't kind of tell them what happened during your shift, or were there any events that were unexpected or good positive outcomes during your shift either. And I think with handling, remember, this child that's sick is somebody's son or daughter, somebody's granddaughter, right? And we're trying to make sure that we're caring for them the best we can, which is why you all do what you do, but we're also making sure that we're setting up that next level of care for success when they're getting ready to touch their hands on that patient too. I don't want to throw them under the bus, right? So this kid kind of sounds like a cut and dry, not really much going on, doesn't it? On the scanner, though, did have a pretty significant subdural hematoma, which you all probably are very familiar with. A large, pretty nasty collection, mostly venous in origin blood, with a little bit of a midline shift there. So some of the neurologic sequelae that happened, or that the providers were seeing over time, was a direct response to that bleed and that swelling in the brain. Does that make sense? Acutely, what happens though, right, is, edema takes time, swelling takes time. So it may be that the pre-hospital said, hey, you know what, my kid was fine. He was up, he was laughing, giggling. Closest ED says, he started kind of acting a little blasé and he threw up a couple of times. My radar's going off. You know what I mean? Uh-oh. And then, become attended by the time he gets to us, because that's time, right? Here's the rest of the story. He had a grade 4 liver laceration. He had a grade 3 splenic laceration. He had, his duodenum was actually torn in half. He had acute on chronic fractures of his ribs and long bones. When they did his secondary survey and took him off the board and rolled him over, pulled his pants down, that's when they noticed that he had anal rectal tears from being abused. He did require several GI surgeries. Neurostatus improved. He did get blood transfused. He was taken out of that home, placed in foster care. And then ultimately that family was charged with child abuse. Now, that's the Paul Harvey, right? That's the rest of the story. But sometimes when we're in our little zone of care, we're not really thinking about all of that, right? If you would have known this or had an idea of this before you got started on your assessment, would it have changed how you assessed your patient? Or should it change the way that you assess your patient? Shouldn't, should it? I mean, you should be assessing every patient that way, right? So it's kind of like, oh my gosh, I didn't even look, or we didn't really focus any on his belly, right? Definitely didn't go there. So anyway, that's kind of like how transports, when you're preparing for these transports, sometimes you just get little pieces of information, but they build up as long as the quality of that information is right? We don't want to speculate or guess, but we have to tell the facts, right? Yes.
I think it's also important.
Let me zap him with this.
I'm just trying to speak up. Mama, I don't think
There we go. One little tidbit of information that made my radar go up was when the pre-hospital gentleman had said that parents were fussing. And again, you heard today from Dr. Goodpasture and from some of the other speakers, you don't want to stereotype people and think about things like that, but that's just a little tidbit of information to put in the recesses of your mind to report, because most of the time, those of us who take care of sick and injured children, if it's not a non-accidental trauma, parents are going to be clinging to each other and crying and be more supportive of each other than being in an angry state. So that's just something that I remembered from his report, which was very good.
Did that make sense on that, like running through that? So that took long because we wanted to debrief and we wanted to kind of talk about just how different it was and how to appreciate each pre-hospital closest ED and then the level 1 trauma center. And, you know, remember, these guys and girls are out in the field, right? I mean, they have what they have in their bags and their truck, and that is it. The closest ED, though, has the ability to stabilize. They have the ability to do a lot. So even though pre-hospital brings them in a mess, they should be able to kind of get that patient as stable as they can. And then the decision would be made was, you know, can we handle this patient, admit this patient, or does this patient supersede our level, and does it need to go on to a level 1? That decision gets made with the attending and the team, and then they set up for a level 1 trauma center. So a lot of communication going between different areas. So this next case, whoever didn't do the first one, guess what? We got some more cases, but this time they should run fast because you guys kind of know what we're looking for now. The case that we've got is a 15-year-old burn, all right? So I need a couple of pre-hospital, a couple of close CD, and then a couple of the level 1 trauma center, and we'll go through this one and see if this one gets a little tighter as far as what we're doing and how we're reporting it. Where's my PICU people? Come on up here. Come on. Come on.
So for today, you're not PICU any longer, you're pre-hospital.
Yeah.
You have to
My
shift your gears in
pre-hospital.
thinking.
Let me get two closest EDs. Two closest EDs. Come on, girls. You can do it. I got faith in you. And then how about we'll do these two and then two from the Iredale table for our level 1 trauma center. All right. So look, I'm just going to tell you what pre-hospital is going after. You all are going to have the dialogue between each other as far as what's happening, and I'll give you information as it comes. So it turns out there was a bunch of kids out, and they were playing in the yard, and they were dipping arrows in gas, and then they were lighting them and shooting them. And then all of a sudden, this guy, you know, he somehow or another he got like where he was pulling back, and the gas was down on him, and he ended up getting burnt, slap up. And so they get a call. EMS gets a call that says, "Hey, come get this guy. He was on fire. He was shooting arrows with gasoline, and you and Elena are going out to save his life." All right? Go.
All right, we pull up, we assess the scene, make sure nobody's on fire.
All right? You do not want to be crispy number 4. All right? So the scene is safe.
We'll assess his airway, make sure he's breathing.
Okay? He is breathing. He does have singed nasal hair.
So he'll probably need intubating at some point. Since
Okay.
He's probably burned his airway.
He is breathing. He's breathing fast, and he's saying that he hurts.
So I don't know if they would intubate at that point.
I'm sorry, do you have a microphone?
Can we appropriately manage his airway
Yes, you
without
can.
intubating
You
him?
can maintain his airway without the need for positive pressure.
So we'll assist his ventilation.
Okay.
We need to obtain the other vital signs. What surface area is he?
Yes, what surface area is he? You remember?
About 25%.
Okay. And how would you know that, being pre-hospital people?
Chart.
Right. There's a bunch of them that's laying on your table that Tammy set out. Anyway, it's a burn chart, and based on that chart of surface area, you can kind of come up with a percentage. Sometimes it's overestimated, sometimes it's underestimated. which can have impact on your patient. But anyway, they're guessing that they're saying there's 25% body surface area that is affected, and those areas included what?
His face.
Face, neck, chest,
Bilateral arms, and his lower parts of his lower extremities.
Okay.
So we need IV access, and he needs some fluid
Okay.
before we pack him up.
All right. So on your vital signs, you saw that he was in sinus tachy. His blood pressure was a little bit on the low side. His saturations were 90%. And you have an IV established.
We'll give him a little oxygen and start a fluid bolus once we get our IV 20 per kilo LR.
Okay.
Pack him up.
All right. And then pack him up. So my pre-hospital's ready. They've got this patient ready to go. My community hospital, represent. All right. So EMS is getting ready to bring you your patient to your ER. Ready? All right. Go.
We would make sure they're.
Wait, they got to tell you report first.
All right, we have a 15-year-old with 25% burns. Where they are on his body. He is on some oxygen. He's breathing 90%. He's got a singed nasal hairs. We've started IV. We've gave him 20 per kilo LR. Family is or isn't with us.
I don't know. Did you assist? Oh.
His level of consciousness is.
He's awake and in
He's
pain.
awake. He's awake and in pain. Yeah, his GCS is 15.
Good.
And breathing fast with a low blood sugar.
After we reassessed after his LR bolus, and his pressure's still slightly low, probably.
Okay. All right. Now go.
Hello?
My man.
I'll switch.
It's out, it's out.
We would make sure he's maintaining his airway, make sure the
Great.
IVs are working properly.
Great.
Get some blood work, maybe a chest x-ray.
What kind of blood work do you want?
I would get just the CMP, BMP, probably an ABG.
Okay.
Obviously do our full assessment, full vitals, make sure he's maintaining the airway. If we need to intubate, then have RT there.
Okay. His serum sodium was 150. His K was 6.5.
So his potassium is definitely elevated. I would probably anticipate transferring him out.
Yeah. Okay. That's a good call. Like, you didn't sign up for all this, did you? You just want to have a good night.
I would anticipate more fluids, bolusing him again.
Yeah, definitely. All right.
They give him something for pain.
Okay.
Yes.
What do you want to give him?
Morphine? Yeah.
So we had a tachypnea and a low blood pressure we gave a normal saline bolus for, right?
Mm-hmm.
But he's also like just been on fire, so he's hurting, right? So your fine line then becomes, can I treat his pain effectively? Can he maintain his airway after I do that? And am I going to bottom out his blood pressure, or can I always give him more fluid and still give him pain medicine? Right?
Right.
Would you hold off on pain medicine if his GCS was working?
No. Okay, so you said you want to give him more fluid because of your electrolytes and kick him out.
Right.
This is your tertiary care center that you're going to give report to. Ready?
That's your turn, Lenny.
You just want to be Vanna.
Okay, so we have a 15-year-old that has 25% burns. singed nasal hair right now is maintaining their airway, could possibly need to be intubated. We've bolused with normal saline, 20 per kilo of LR out in the field. Vital signs, he's had kind of a lower blood pressure. Potassium was elevated. Let's see, we do have IV access. Got that one.
All right, with my level 1 trauma center, what you want to do? This patient's coming into you in 3 minutes. You all are in the bay waiting on it.
Set up your team and set up for intubation first of all.
Okay. Okay. So you've got your airway stuff out and ready. He's a 15-year-old, so probably not going to be messing around with the neonatal size tubes, right? Okay. And then he's received how many boluses? Okay. Right. So we've got an LR and a saline bolus that are in, right? Were there any maintenance fluids ever started? Or were there 2 times maintenance fluids started?
What did the first handlers, first contact, did they start an IV fluid or just start an IV and
They
gave a
did.
bolus?
They started an IV and gave a bolus.
So then what fluids would they be, do we need to change that to something with electrolyte if they didn't do that?
In the field, they're going to have saline or saline.
With lead beforehand, perhaps?
So what kind of electrolytes do you want to add in that solution? Okay. Everybody's going to get blood draws in the ED, right? Just it's the way of life. You come in my ED, you're going to get blood. So, but I probably would steer clear of any electrolyte fluids because I've got such a bad situation with my sodium and potassium now.
So keep it basic LR?
I would keep it an isotonic solution, whether that's LR or saline. Critical thinking question would be is why are his labs, why is he hypernatremic, hyperkalemic? What's the mechanism of injury? He's burned. Anytime you damage or cells die, what do they release? K. K is the primary intracellular ion, right? So they're going to have massive exhalation of K. Sodium causes dry. 25% body surface area, you have a huge amount of insensible losses that are going out because of that body surface area. So you're going to have to really tank these people up a little bit more than, and then again on our burn chart, we kind of talk a little bit about fluid resuscitation management that you're going to want to do for them.
What about treating the wounds? I've never heard that addressed. What would you have done with those burns during transport?
Yeah. Well,
Maybe minimize that loss of moisture.
yeah, I don't know. I mean, I don't think that it was ever addressed. But you all are the level 1 trauma center. What do you want to do with them? Break out some saran wrap. Just wrap him all the way around with saran wrap, right? We can't put him in the bowel bag. He's too big, right? Where's my ED people? What are we going to do with this 25% body surface area burn when they roll up in there and everybody gawks at it? Paula?
We never activated the trauma code. This kid's going to be a trauma code, so that it will get our resources rolling. That'll notify the burn center, which we are, to get rolling, get the tank ready, let's go. So that's the first thing we need to do. We need to activate the trauma code. That'll bring us the resources we need.
Yes, ma'am.
What does that do?
It brings the trauma surgeon, it brings a gaggle of people to the ED. And when they show up and we can run through that primary and secondary, then we'll know immediately what we need to do. Does this kid need to go to the scanner? Do we need to intubate? Can we get them up to the burn ICU so they can be tanked and they can get all that stuff taken care of? We can do that in a matter of minutes. Yeah, we should have done that first. Yeah.
We're not. No, we're not.
That's okay.
No,
have
no.
specific criteria, whether a trauma surgeon comes within a certain amount of time or whether he shows up right out of the gate, things like that. So, it's good stuff.
If you were a smaller community hospital, right, and you knew a burn was coming in and you had some like super skin nurse, you know, I mean, they could at least draw their resources there, wound team. I mean, at least you could tap in before we go to a level 1 trauma center. It's just that process is to give the heads up to everybody that may come in contact with that patient's need, for their needs, to try to get them all ready and there for that patient, right?
You know, I was thinking in terms of the infection potential and all that transport, and not having those wounds somehow pressed.
I mean, they washed hands, I'm sure, right? Did you wash your hands?
Hey, he made it there alive.
All right. That's right. EMS said he made it to your ER alive. Peace out.
Burn centers don't want you to do anything. They don't.
Yeah.
All they want you to do is basically cover them with something that's
Clean and dry.
And dry.
That's right.
The thing with wetting everything has gone away because
Yeah.
they become hypothermic.
Yeah.
They don't want a lot of Silvadene or anything on them because they're going to wash that all off.
Yeah. Most places, you're right. I mean, most places have burn sheets. I think every ED should have burn sheets or burn
And it doesn't
towels.
have to be sterile. I
Yeah.
mean, some places will still do sterile, but it really does not have to be clean and dry, just covered.
Right.
Warm. And warm. Yeah, you want to keep it warm because they've lost skin, they're losing heat.
Right. So did that one make a little bit better sense this time? Did you see how it kind of came together? It's starting to like narrow in a little bit more. Yes. Hey, Debbie.
One of the things, just because I can hear the voices of Ernest and Donna in my head, is it needs to be LR, get rid of normal segment,
Yeah.
and you need to start the Parkland formula. Parkland formula, which is 3 to 4, depending on which one you ask and stuff, and it's 3 to 4 meals per kilogram times your percent run, surface area. So it's actually measured, you're just not bolus and bolus, and then you want to get a Foley at some point because you want to see how, what your resuscitation, and they may have to tweak it as you go along, but if you just pour in normal saline, you're going to give them hypochloremic acidosis, and you don't want that.
Nicole?
There's a burn mixture that's out on one of the tables out there, and below that is some smaller totems. You can feel free to take those, you can put them up in your EDs, in your break room, those types of things. And there is on our, you get to it from external, you go to like the website, it's kind of hard to find, but there's a calculator from the burn center that if you went onto our website, you could just say how much, how old the kid is, how much they weigh, how much surface area, blah, 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 and pay how much fluid to do.
They'll want to know exactly how much they have.
Yeah. Oh, yeah. I mean, just like, again, giving that report off at the end of your shift, you want to know what the total in was for your shift and what the total out. Same way, right? It's just going from facility to facility. They told me to hurry up. So this kid had some pretty bad burns. He got some skin grafts. He did not require intubation initially. He was fortunate enough to maintain his airway in high acuity. He didn't need to be intubated, which was really lucky for him. The other thing that kind of came out on this, and I wanted to share this, was there may have been a component of bullying in this whole thing, but again, it's something like, what, 10 years ago we really didn't think so much about bullying being in the differential of what caused or what could have caused. But anyway, that's that one.
If they're all about the same age kids, then it's gonna be the dare stuff. Who's gonna be guy enough to do this things, they're gonna dare each other to do it. So it's gonna be that, even it's all males, it's gonna be.
Those
a group
stupid
of-
males.
Yeah. So it's like, maybe not bullying, but just that heady community of young males.
Yeah,
animals.
yeah. So in the essence of time, we'll run through this real quick. This is a 9-month-old unresponsive. So let me tell you how this went. Mom said she was feeding her baby, and the baby, while she was feeding, fell out, become unresponsive, turned blue. EMS got there, brought the patient to the ER. So mom's feeding this 9-month-old, falls out. EMS gets there, the kid's GCS is 3. They intubate in the field with a King airway, and they bring this patient into the ER. The ER, sure enough, says, yeah, this kid is a GCS of 3. They replace the King airway with an ET tube. They establish IV access. This is what happened. The head CT that they did out there was normal. The GCS was 3. Your blood gas that they got was this. pH was 739, PCO2 of 21, had good PaO2s of 125. Your bicarbonate was 13. You had a base deficit of 10, and your lactate was 20. All your labs were normal. They gave boluses for hypotension. Bicarbonate was given because of this metabolic component. And out in this referral hospital, they actually, because they didn't know what was going on with this kid, sent off toxicology. They did blood and urine. On the blood alcohol, it came back as 489, and the nurse said, you know, I used some alcohol when I was prepping my site. Maybe I contaminated my sample. Let's repeat it. Sure enough, when it repeated, it was 489. Remember, you're legally drunk at 0.08. So this child, half of his plasma was alcohol. What do you think about that? You know, we actually flew for this kid, and the kid did make it. Came to pick you, actually ended up needing to be dialyzed to get that alcohol out. The rest of the story happened. Mom was very tearful. I remember when me and Kathy, that was my partner that day, when we walked into that ER, Mom was way far away in the corner, and she was just sobbing, right? Like, but didn't have any patient contact, which I thought was really weird, like not holding a hand or, you know, rubbing her hair or something. I just thought, man, that's really weird, and she was just sobbing. So turns out she was wanting an evening for her and her significant boyfriend at the time, and so she was putting vodka in the kids' bottles over time so that way the kid would sleep during the night while she went out. So we brought in a drunk 9-month-old that ended up needing dialysis in order, and of course that child got taken away as well. The thing is, though, right, you get hung up on GCS of 3 or, you know, altered mental status. I mean, it's I think sometimes easy to get into cookie cutter mentation of it's got to be head, it's got to be this, it's got to be that. And sometimes if you have to assess everything about these patients, right? The last one was a 20-month-old submersion injury, and this was a flight down to High Point. This was actually the second submersion injury in this pool down that way that was in an apartment complex. What happened with this kid was the 20-month-old was with the family, was swimming in this community pool with no lifeguard on duty, and the parents look out and they thought that their 20-month-old was playing dead in the water, and so they didn't do anything. EMS gets to the scene, they do CPR for 25 minutes, they intubate, place an IO. They brought this child to the closest ED. That ED actually requested us for a flight, which we did, and came down and picked him up. There was seizure activity from the giddy up. There was hypothermia because of the mechanism. This is the blood gas that we had when we got in there. pH was 6.84. PCO2 is 42. Oxygenation was 427. Your bicarb was 6 with a deficit of 24. And he was a train wreck from the time we picked him up. He's still with us. He's a frequent flyer. He comes in. He's neurologically devastated. He's trait dependent. He has horrible neurological sequelae with that. So I'm going to turn it over to Tammy now because she's like sitting here being Vanna. And go from there.
So we put this slide in here for some keys for you to take back to your practice. We hope you can think outside of the box with some enhanced provider assessments and interventions. Always try to be one step ahead of the patient and anticipate needs and any differentials. Try to think of best transport services and modes for the patient. Really work on thorough handoff communication. We'll talk about the SBAR format in just a few minutes, and make sure that you have someone involved with the family to give updated information. Also, for those of you who have had the pediatric trauma life support, this is a review, and I think one of our ladies, I think one of you back there from the PICU, you talked about scene size up. We always, of course, we need to take care of ourselves first, because if we injure ourselves at pre-hospital, of course, we're not going to be any help to our patients. So you always want to make sure that you size up the scene and make sure that it's safe for you to go in. Try to get a general impression, just kind of get a feel. Does something not feel right? Does it not look right? One of the gentlemen this morning, I think he was a paramedic, he was sitting over here at this table, and he had asked the question about charting. And I think one of the things that we learned in some of our charting was, as far as pre-hospital, if it doesn't look right, if it smells funny, chart anything, because as Dr. Goodpasture can attest to, all of that really helps. Look at, your AVPU scores, alert, verbal. Do they respond to pain, or are they unresponsive? You also want to think about, again, that airway and C-spine immobilization, breathe-in circulation, good set of vital signs, and go over that initial assessment again to make sure that there was something you didn't overlook. Get a sample history. Signs and symptoms. Do they have any allergies? What are their medicines they're on? Last oral intake, past medical history, and events leading up to the situation. So I kind of did SAPMLE, but you kind of got the gist of it. One of the other things, another little thing that we talk about is the DCAP BTLS. Again, this just stands for deformities, contusions, abrasions, perforations, burns, tenderness, lacerations, and swelling. And of course, the tick, tenderness, instability, or crepitus. All of these things you want to do when your primary and secondary survey, and document anything that you see. Documentation, I cannot express how much and how important documentation is. This particular one right here, we have huddle up or snuggle up. So do we want to assess our patients kind of rapidly and just kind of stand around and think, well, what's going on? Or do we want to hurry up and make a decision and report all of our assessments and get these patients to the care that they need? Some transfer considerations. We want to look at speed versus specialization, skill sets, equipment. Now, one thing that you will hear, and my team members hear me say this all the time, our pediatric patients are not little adults. You have to have pediatric specific equipment for them. You want to think of weather and time and distance, and somewhat Paula in the back did bring up leveling criteria, which is very important. Some of the other things, and you know how anytime that we're transferring patients, how busy it is. You're trying to get all of this paperwork together and labs and copies and no telling what kind of computer system you may have, and trying to get all of your work done, all the patient's charts, your lab results, any of the patient's belongings, make sure that you communicate to the family, any referral center resources, and one of the other things is if there are any casualties as well. So this is just some literature that we have referenced in regards to specialty teams and outcomes. So we hate to brag, but we did put a little picture of our neonatal pediatric critical care transport team up there. We also have rotor wing services available as well. One of the other things that I want Jonathan to come up and talk with you a little bit about is our handoff communication and SBAR. Again, I mentioned earlier that as part of some of the safety education that we're going to be undergoing at our institution is talking about the SBAR. It's a phenomenal, short, cut to the chase way to report to your other hospital. Jonathan?
So, can everybody hear me? So basically, SBAR is like the nuts and bolts of a report that you're wanting to give on your patient. It's been well studied and also proven to be an effective tool for giving report that also can carry over that important information from the providers. You've all taken report from that nurse that wanted to start from the time that your patient was conceived until today, right? You really don't need to hear all of that crap. You just want to know what is important for you, right? So SBAR kind of shaves it down, gets you focused, and hopefully you're going to, carry those key elements over with you in your care. The situation, again, is what's going on, what happened. Background, was there any history up until this point? And again, what did you do about that situation? What was your assessment and actions at that particular point in time? And then recommendations when you hand them off. Super important, but super easy tool to use if your facility's not using an SBAR per se, but they're using some type of handoff. We've really embraced it at Brenner's with regards to, doing it with every handoff that we do. And the huddle up thing that Tammy showed you earlier, that's also something that we're doing, and I know that the ED does it as well, is, if you know that you're getting something in, it's nice to have that clear role delineation of, okay, you're going to be doing this, you're going to be doing that, and so that way when your patient shows up, it doesn't look like everybody's spinning around and not doing anything, right? Everybody has an assigned role in that particular day, shift, admission. So if you don't, or if something comes through and it kind of blindsides you, it can kind of make your day bad, right? Because you didn't have any kind of a plan before you ever got started. So the SBARs and the huddle ups are definitely two tools that we're using at our organization to try to help improve the quality of care that we provide our patients, but also help improve communication between professionals as well.
Thank you, Jonathan. And again, don't forget the family. We are very fortunate to have a child life department that does spend time in the pediatric OR and the pediatric ED. They are there for consoling, counseling, spending time with children, providing some diversion. They are a wonderful asset, and please visit their table out here, the child life. Family feel powerless. They kind of don't know what's going on. We as parents like to make sure that we're in control and, that we're in there with our children. Now, we encourage family to be right in there if they want to be. I think it's important for families to see that we are working hard and trying to do everything we possibly can for their baby. That is very important. It's also important to assign one single person to be with that family member and to keep them updated. And let them ask questions, let the family be in there if they want to. Do you all have any questions? I really want to thank you all, especially our participants. I see some of the Iredale people left. I think they were probably afraid we were going to call on them again. No, but thank you all so much, and I hope you take to heart some of the things about communication and just thinking outside of the box, and remember to always try to stay one step ahead of your patient. I really appreciate all of your participation. Thank you, and see you tomorrow.